Good evening. Today, we're going to be discussing some pretty cool cases on retina. I'm joined with two incredible colleagues. First, I want to introduce Carolyn Majcher, a professor of optometry at the Oklahoma College of Optometry. And I also have Eric Schneider, a vitreoretinal specialist at Tennessee Retina. Thank you both for joining me.
Pleasure to be here.
Thanks for having us, Yasha. This is gonna be great.
Awesome. So I'm going to have Dr. Majcher take it over. We're going to start into some cases.
Great, so I entitled this first case, Don't Wake the Sleeping Dragon. And with this case, I really want to introduce a vascular anomaly that we couldn't even directly visualize until the advent of OCT angiography. And this was a 68-year-old male, and he had a history of dry macular degeneration, which had only ever been treated with AREDS2 supplements. His best corrected acuity was a little bit reduced in the left eye to 20/40 plus. And looking at his maculas here on the color fundus photography, we can see that there's some macular drusen as well as some pigmentary changes, as well as a little area of non-central geographic atrophy. And in general, these macular degeneration findings seem a little bit worse in the left eye compared to the right. Of note, there is no hemorrhaging, no exudate, obvious subretinal fluid to suggest that there's any active choroidal or subretinal neovascularization present. Here on the structural OCT and OCT angiography of the right eye, it's pretty unremarkable. We can see that there's a little bit of disruption of the photoreceptors or the ellipsoid zone here in the right eye, but there's no fluid, no PED, definitely no neovascularization that we can visualize. And then when we look at his 6mm angioplex scan down here, what I really want to focus the attention on when we're looking at outer retinal diseases, we have a lot of different presets on the OCTA that we can look at. We want to look at the ORCS lab, ORCC, which stands for outer retina choriocapillaris. And that segmentation plane includes the photoreceptors, the RPE, and the choriocapillaris. So it's going to be most valuable for detecting subretinal or choroidal neovascularization in macular degeneration. And we can see in this patient's right eye, it looks like there's no neovascularization, but perhaps an area of hypoperfusion of the choriocapillaris. Looking now at the left eye structural OCT raster scans, we can see that there's a shallow separation of the RPE up off of Brooks membrane, and that this pigment epithelial detachment has an irregular contour to it, and this is within the nasal foveal region. In the scan just above that, we're catching this area of geographic atrophy where we have loss of the photoreceptors and choroidal hypertransmission. I think what's really important in these images is that we recognize that this shallow irregular PED, or double layer sign as it may be called, should be a high risk sort of red flag to you to say that this patient probably has sub-RPE or occult non-exudative choroidal neovascularization present. Of note, right, there's no fluid around this lesion, so it's likely non-exudative choroidal neo. We got to use OCT angiography to visualize it best. So here on our OCT angiography scans of the left eye, this is a smaller 3mm scan, and I've decentered it on the nasal foveal region so that we could specifically look at that shallow irregular pigment epithelial detachment. And we can see on the ORC preset that there is a well-defined neovascular complex. And on our B-scan overlay, we can see there's a red coloration within that pigment epithelial detachment. So again, telling us that this is a vascularized pigment epithelial detachment. So our assessment for this eye is that this patient has neovascular AMD, because we clearly have a neovascular net on OCTA, but that it's non-exudative since there's no fluid, there's no hemorrhage, there's no exudate present. So we decided to monitor this patient in-house very closely every 3 months and stress the importance of home Amsler grid monitoring. Unfortunately, he no-showed that 3-month appointment, but did come up 6 months later. And at that point, he was coming back just saying, my vision's stable, I'm here because you asked me to be here. So his vision is unchanged, his acuity is unchanged, he's still 20/40 plus. And on fundus examination, though, we can now see that there's some subretinal hemorrhage as well as some exudate, really hallmark features of exudative conversion that warrants a referral to a retina specialist at this point. Here in Zeiss Forum, we're able to synchronize and compare his baseline and 6-month follow-up raster scans. And on the 6-month scans, we're seeing some of this new overlying subretinal and intraretinal fluid. Another feature that should really scream at you that this is now converted to active exudative neovascular AMD and certainly warrants a prompt referral to a retina specialist for anti-VEGF treatment. And in Zeiss Forum Retina Workplace, we can also do a macular thickness analysis, and that's going to allow us to compare and synchronize 3 macular cube OCT scans. As we can see on this video here, as we're kind of scrolling through these 3 cubes in synchrony, over on the left-hand side, that's one of his initial exams with us, where he didn't even have the PED present. The one in the middle was the first exam I presented to you, where he has that shallow, irregular pigment epithelial detachment and non-exudative CNV lesion. And then on the right-hand side is when he's converted to exudative AMD. And we can see there's intraretinal fluid as well as intraretinal exudate. Here's his baseline and 6-month follow-up OCT and geography scans. And we can see the change in morphology of the choroneovascular membrane lesion, where it almost looks like it's a bit larger, and there's a fringe of these like lacy looping sort of capillaries on the margin of the lesion. I like to think of it as like it's springtime and the tree now has like leaves on the tree. So just the morphologic pattern change of this membrane on OCT and geography is suggestive that it is now active neovascularization. So I want to highlight what happened in this case. How this patient went from a non-exudative membrane to an exudative membrane, that there's a very high risk of non-exudative choroneovascularization to convert to the exudative form of the disease. And research would suggest that the risk of conversion in eyes with non-exudative CNVM is about 15 times greater compared to those that don't harbor these types of lesions. And so that being said, I think it depends on your comfort level, whether you want to refer these patients to retina right from the get-go, even before there's fluid or hemorrhage, or if it's something you feel comfortable monitoring in-house if you have the technology to do so.
All right. So that was an awesome case. So Carolyn, when you're thinking about these patients, certainly I thought what was really fascinating was you brought this patient back in about 3 months. And now normally for somebody with intermediate macular degeneration, we'd normally bring them back in 6 months. And I love the fact that OCTA was able to identify this to be higher risk. So Eric, actually a couple questions. Do you use 4C home device or any other home monitoring devices when you see this type of patient? And is there any role for prophylactic treatment if we know that their risk of progressing to exudation is so much higher?
Those are great questions, Yasha. I am a 4C home user in my practice. I think it's a great device even for patients with intermediate macular degeneration, but I think it's even more helpful in this specific instance. These are patients, as Carolyn pointed out very nicely, that are at incredibly high risk for conversion, and I want to catch these patients as early as possible. We certainly have great evidence throughout our various clinical trials that the earlier we treat patients, the better our final visual outcomes are. And so I think it is incredibly important to monitor them, and I think 3 months or more frequent is very helpful. The other thing is, in the future, are we able to put these patients on, home OCT, right? Another Notal product, but I think that's another option once that becomes potentially available for monitoring. Regarding the question about prophylactic treatment, I think that depends. I think in general, we have reasonable data showing that there's probably not a huge benefit to treating patients without active exudation. Having said that, you have to take the patient's circumstances into account, right? If I have a patient who is monocular, perhaps, who had a really bad outcome, someone who potentially has transportation, social issues, who feels strongly about doing the ultimate in terms of prevention, I think you could certainly offer to that to patient. I think routinely I wouldn't do it. I think there are certain circumstances I would certainly offer it.
Yeah, I mean, I think that's perfect. It's interesting for the listeners, there were 2 studies that looked at prophylactic treatment, one called the PREVENT study and one called the PROCON study. And that looked at quarterly injections of anti-VEGF versus sham. And what was interesting was the rates of exudation were exactly the same. All right, well, fantastic. Eric, I'm going to have you take over and we'll move on over to our next case.
A great case, Carolyn. I'm going to move on to my first case, which is what I've entitled Looks Wet, Acts Dry, and this is about suspicious spaces and age-related macular degeneration, sort of the flip side of what Carolyn presented, so I think this should be an interesting juxtaposition. So this is a 71-year-old patient who was referred to me for suspicious drusen, and we can see, on color fundus photograph, this patient has extensive drusen in the central macula of both eyes, with a large drusenoid PED centrally in that right eye, with pigment clumping in both eyes. We don't see any evidence of exudation, whether hemorrhage or lipid present in either eye. If you look at our structural OCT of the right eye, we again get a better view of that drusenoid PED, which is rather large. And you see at the base of this drusenoid PED some small hyporeflective spaces, which could be suggestive of exudative subretinal fluid, but also have the appearance of a tenting or draping artifact in which this large subretinal lesion prevents the retina from completely conforming to the RPE surface. I did get a fluorescein angiogram based on those structural OCT findings, and we see in the early and mid phase of the FA, we see some staining of drusen and some more prominent staining of the drusenoid PED, but no clear leakage, and you certainly can't identify a CNV present in either eye. Given that it can be challenging to interpret a traditional angiogram in the setting of, a lot of staining from drusen or vitelliform material, I typically get an OCT angiogram, and this is a 6x6 angioplex image from the Cirrus 6000. And we see on the en-face image on our ORCC slab that Carolyn nicely defined at the previous case, we don't see any obvious CNV en-face. And then you can see the corresponding cross-sectional image with flow overlay. I actually scrolled through this entire thing, and you see no significant flow abnormalities in the outer retinal area, again, suggesting there's no CNV present. So I elected to observe this patient. However, I had some suspicion. We thus monitored this patient relatively carefully. This, again, sort of corresponds to Carolyn. She has a non-exudative CNV, and she's monitoring the patient carefully. In this case, we have something that looks like it could be potentially exudation, so we'll also monitor carefully. But you see in the 3-month follow-up on the structural OCT, we see very similar appearance to those hyporeflective spaces at the base of the drusenoid PED. And then about 5 months later, we see the increased size of that drusenoid PED with the development of some interval geographic atrophy. But again, our OCTA shows no evidence of a CNV. We do see some increased flow signal from the choroid, which is really a window defect as a result of that evolving GA. So I saw no progression, therefore I continue to feel there's no CNV present, and I space this patient out. We see with longer follow-up, the drusenoid PED continues to get larger with increased geographic atrophy, and then about 3 years after initial presentation, we see that that drusenoid PED actually collapses completely with more extensive central geographic atrophy. And at this point, I feel pretty confident that there's no choroidal neovascular membrane present, as there's very little happening in the RPE. I just wanted to highlight some take-home points from this case. I think, number one, we have to remember that not all hyporeflective spaces represent exudative fluid. As the case with this particular patient, the draping or tenting artifact can be a common cause of a hyporeflective space that can be seen in the setting of AMD, but there are other potential confounding conditions that I think we commonly encounter in clinic. First and foremost, I think our vitelliform lesions, which are sort of the bane of my existence. Acquired vitelliform lesions are relatively common in age-related macular degeneration, and the vitelliform material which builds up in the subretinal space is hyperreflective, but it tends to evolve over time and actually degenerate, and you'll get sort of this hyporeflective cleft, which actually can get larger over time, which can be suggestive of subretinal fluid, but again, it doesn't tend to increase retinal thickness, and on OCTA, you wouldn't see any flow. We also commonly see cystic degenerative changes overlying geographic atrophy. They tend to be sort of vertically linear and again, don't change much over time. But as we've seen from many studies over the years, geographic atrophy can harbor macular neovascularization. And if we see these areas of cystoid macular increasing, that could warrant treatment. Outer retinal tubulations are changes we see in more advanced dry macular degeneration that tend to have a more of a round appearance, and so maybe a little less characteristic of subretinal fluid, but certainly depending on the cut on OCT can be suggestive of subretinal fluid. And finally, this is not specifically seen in macular degeneration, but macular telangiectasia type 2 can be mistaken for AMD due to some of the pigmentary changes or vascular changes we see, and those patients very commonly have intraretinal cavitary lesions lesions or hyperreflective spaces, which look a lot like intraretinal fluid. So those are things that we need to look out for that could represent sort of pseudo fluid. And so that's why I think OCTA is very valuable. I do want to make the point, though, that a negative OCTA is helpful, but it's not perfect. I think the negative predictive value of OCTA is somewhat limited, especially in comparison to the positive predictive value, as we saw with Carolyn's case. And so I consider a negative OCTA a reduced likelihood that there's a CNV present in these cases, but I still tend to follow them relatively closely. I do also want to make the point that fluorescein angiogram in many of these situations, like say, for instance, patelliform lesion or geographic atrophy, cannot be very helpful due to the intense staining, or in the case of GA, window defect that can be present. That can make it very challenging to detect any, subtle leakage that could be present from an accompanying choroidal neovascular membrane.
Eric, what an awesome case. And, I think by the virtue that you were able to get the FA, the OCTA, and really build your confidence that this was truly a non-neovascular process, you were able to save this person a whole lot of injections. Carolyn, when I was sort of looking at this case and I was worried about the possibility of atrophy. So, when you go back and you look at that pigment epithelial attachment, what is it that you were seeing that made you particularly worried?
Yeah, I see a lot of patients that have these like large confluent soft drusen or like drusenoid pigment epithelial detachments that often collapse and then eventually form an area of geographic atrophy. And prior to the collapse of the drusen, you'll often see like some attenuation or beginning disruption thinning of the RPE that allows for choroidal hypertransmission kind of through the drusen and into the choroid. And kind of that midpoint where you had that occurring and we're looking at the OCTA, it becomes a very difficult and challenging situation to interpret that OCTA, because I think there are some individuals who would look at that transmission artifact and interpret that as being an area of choroidal neovascularization when it's actually just sort of a transmission artifact that's going on.
Yeah, absolutely. And, Eric, just a question for you. I've seen this at sort of like the drape sign, have you described it? Where else can we potentially see subretinal fluid in the absence of any neovascularization?
Yeah, I think anytime you have a large PED, I think, most commonly you'll see at the base, but we have seen it certainly at the apex of a PED, and that could be another suspicious area. I would treat it exactly the same. I still think OCTA can be quite valuable in evaluating patients with that sort of different configuration of hyperreflective space with a PED.
Yeah, absolutely. I think Giuseppe Caricus really described this finding to us, especially showing OCT and ICG images really corroborating the fact that there was no neovascularization. And, the good news is if you identify it, you obviously can save the patient a lot of injections. The bad news is that it typically represents some level of sick RPE. And this is something where we do want to counsel them a little bit about the possibility of collapsing. And, obviously really great for this patient in the short term, but as we could see, there was subfoveal atrophy at the end of it. So we'll move on. Carolyn, we're going to turn back to you for another wonderful case.
So this next case is sort of a BOGO, buy one, get one. So a small case series of things I missed on clinical examination, diabetic retinopathy edition. And what I love about OCT angiography is we get such detailed, fine, high resolution of the microvasculature that we're able to detect lesions that we can't see on our clinical examination. And I really want to highlight the utility of OCT angiography montage in diabetic retinopathy assessment. And so in a montage image, we can actually get a 14 by 14 millimeter total scan by taking a series of 5 8 millimeter scans, and then the machine automatically knits them together in the angioplex. And I think it's really useful to visualize areas of retinal non-perfusion as well as areas of pre-retinal neovascularization that could signify early proliferative diabetic retinopathy in our assessment of patients with diabetic retinopathy. And so before we dive into the cases, I do just want to do a brief review of what pre-retinal neovascularization is. We know these are new blood vessels that are growing up outside of the retina, and it's usually, on the posterior hyaloid of the vitreous face, but within this posterior vitreous. So this first case is a 52-year-old male, long-standing, poorly controlled type 2 diabetes. His vision's pretty good, like 20/25. And so how are we going to stage this diabetic retinopathy just based on the color fundus photography or the clinical examination alone? When I saw this patient, I assessed him as having either severe or very severe non-proliferative retinopathy. There's some intraretinal hemorrhaging that's pretty severe in all quadrants, perhaps some like venous beading, a lot of cotton wool spots, but I didn't see any obvious areas of neovascularization, pre-retinal vitreous hemorrhage, traction, anything like that. Here's the Angioplex 14x14 OCT angiography montage, and we're looking now at the superficial preset. So we want to look at the inner retinal circulation when we're dealing with inner retinal diseases like diabetic retinopathy. And here we can see there's areas of non-perfusion, especially looks like in the superior temporal arcade and the inferior nasal arcade here. And then here on the vitreoretinal interface, so on the right-hand side of the slide here, this is the vitreoretinal interface or VRI that's going to show us any blood flow anterior to the retina within the vitreous. So this is designed to detect pre-retinal neovascularization. And in a healthy eye, the vitreoretinal interface should be void of signal, completely black, because the vitreous is inherently avascular. So this VRI was designed to detect early pre-retinal neo, and for us, proliferative diabetic retinopathy when we're assessing a patient with diabetes. In this particular case, we can see that it reveals a small area of neovascularization elsewhere in this inferior temporal arcade. Here I've just magnified that area of neovascularization elsewhere and given you the corresponding cross-sectional B-scan overlay. So I like to put my slice navigator through any area that shows up and just confirm, is there vascularized tissue on top of the retina on cross-section? Yep, right, so I can see this tissue up on top of the retina. It looks kind of reddish or pink, which means it is perfused or vascularized. So our patient was diagnosed as having low-risk proliferative diabetic retinopathy. That this diagnosis was assisted with OCT angiography, and I'm willing to admit I missed this on clinical examination. Referred him and he got PRP. This next case was a 60-year-old male, again with type 2 diabetes, 20/20 vision, relatively well-controlled at diabetes actually of a 7.3% last A1C. And how are we going to stage the retinopathy just based off the color fundus photography alone? It looks like there's some intraretinal hemorrhaging, a few cotton wool spots. I was thinking maybe moderate to severe non-proliferative just based on my clinical assessment alone. Here's the superficial as well as the vitreoretinal interface OCT angiography montage. And we can see in the inferior nasal aspect of the montage, there's a lot of retinal non-perfusion. And around that region, there's an abnormal sort of collection of blood vessels that carries over into our vitreoretinal interface preset. So if it shows up on that VRI, we have to be suspicious that this is pre-retinal neovascularization and early low-risk proliferative diabetic retinopathy. Here I just wanted to show you how subtle that area of neovascularization elsewhere is on color fundus photography and clinical examination. And it's round in shape, right? So it'd be easy to look at this and mistake it as perhaps like a large dot blot hemorrhage. And here I'm just magnifying it for you here. What I love about the Claris ultra wide field imaging is that you can blow up a specific portion of that image and still get really high resolution detail where we can see the fine vessels within this neovascular complex. So this patient, again, diagnosed as having low-risk proliferative diabetic retinopathy that without OCT angiography would have been missed on clinical examination alone.
Really awesome cases. And, Carolyn, I feel like a lot of us have this device, right? And we're probably not capturing these really beautiful images. So what are you telling your imager are you directing them to get all of these quadrants to auto montage, or does the machine kind of guide the imager as to what to do to be able to acquire these beautiful images?
Yeah, so at the School of Optometry, I actually have students or residents that are usually taking these scans. And so what's really nice is, we have students that kind of rotate through. So they always have to kind of relearn. It's not a technician who's used the machine for years and years, but this is really self-explanatory. It will move the fixation target through the 5 different scans and basically just kind of reline the patient's pupil up. It goes ahead and takes it. At the very end, it auto montages it for you. It shows you the draft result. And if at that point you want to retake any of those 5 individual scans, you just click on it and you'll automatically be able to retake it.
Yeah, that's so cool. And I love the fact that there's some guidance to make
Mhm.
this a much simpler process to get these beautiful images. I feel like, Eric, maybe I'm a little bit ashamed my images don't look as good. But certainly I feel like I've learned so much just sort of seeing Carolyn's presentations to be able to try and improve our own imaging output. Now, I had a question for you clinically. When you're thinking about these patients, are you getting ultra wide field FA or are you switching over to these OCTA montages?
Yeah, it's certainly a combination. I think, depending on the patient's appearance, sometimes, as Carolyn showed very beautifully, and I will say these are some of the most gorgeous montage OCTAs I've ever seen. I mean, these are truly remarkable. I think some patients, I do manage with just OCTA, right? I think some of these more patients with more extensive findings, I still find myself getting ultra wide field traditional angiograms. I think, one of the things that I think we're missing, with OCT angiography, obviously, is the leakage component, right? And so, are we seeing leakage, in the macula? Are we seeing, peripheral leakage suggestive of more decompensated, vascular tracts in the periphery? I also find, despite what we were seeing here with these 14 by 14 montages, I think oftentimes I want to image all the way out as far as I can get, 100 degrees, 120 degrees to really look at, peripheral perfusion, which I think really has an important impact on patient prognosis. I will say, leakage is great to help evaluate kind of the overall status of the retina, but it can also be somewhat confounding or obscure, a better assessment of the extent of non-perfusion. So I actually find OCTA to be a better a tool for looking more precisely or more quantitatively the extent of non-perfusion. And certainly if you're trying to track these patients longitudinally, because you don't get that artifact from leakage. But again, I still think that ultra wide field traditional angiography has a role in our clinics today.
Yeah. Yeah. It's actually a really great point that this is a super cool tool. But actually, what we learned from the DRCR protocol AA, which actually evaluated ultra wide field FA imaging, is that there is prognostic value to peripheral leakage. And so, even if you do have a patient with severe NPDR that has a lot of leakage relative to a small amount of leakage, we're certainly going to be more worried about the individual with a lot of leakage. Really, Carolyn, amazing case. I'm going to turn it back over to Eric to end the session.
Another great set of cases, Carolyn. Because you presented 3 cases, I will present 2. I guess I can't quite match you, but I don't want to present a single case. So this will be a couple of interesting cases in which we'll look at decoding atypical CME, and we'll call this all that cysts is not edema. So this is a 58-year-old patient. It's our first case who was referred to me for CME, and you can see very clearly on these beautiful Claris 700 color fundus images, you can actually see those cystoid spaces present in the central macula of both eyes. If you squint, I think just correctly, I think you can see that there's a little bit of loss of the retinal transparency in the parafoveal region, and the vasculature in that parafoveal region is also somewhat anomalous, and we'll see why that is in a bit. If you look at the structural OCT of both eyes, you see that there are these intraretinal, these are these inner retinal, I guess, hyporeflective spaces. However, the retinal thickness overall is relatively normal, which is an important point. The outer retina is relatively intact. There's a small area of ISOS disruption, kind of maybe nasally in that right eye, but otherwise it looks relatively intact. This is a Claris 700 fluorescein angiogram, kind of mid to late phase, and you see that there's relatively prominent staining in the temporal parafoveal region of both eyes. There's actually a little bit of staining or even leakage in the superior nasal region in that right eye, but we don't see any evidence of other microvascular abnormalities, such as microaneurysms, anastomotic vessels. Certainly, we can't see any clear evidence that there's a choroidal neovascular membrane present. So the question is, where is this cystoid macular edema coming from? And this is where the OCT angiogram comes in. This is a 6x6 HD scan on the Cirrus 6000. This is the superficial capillary plexus, and you see a couple of important features here. So in both eyes, we see some feeding arteriole is somewhat dilated, coming into the FAZ area, and multiple draining venules. And what's really striking here, if you look at the central region where the FAZ should be present, you see a significant rarefaction of the parafoveal capillaries with increase in the intravascular spaces. And basically these, this capillary bed is kind of growing into the FAZ, resulting in a very anomalous FAZ shape and size. Really, if you look at that left eye, the FAZ is almost completely missing. But where I think is really cool is if you could look down the next slab down. So if we look down at the deep capillary plexus, this is where we can see, I think, more obvious changes suggestive of diagnosis. So here we see these telangiectatic vascular changes, certainly temporally in both eyes, and maybe really 360 in that left eye. But this is certainly suggestive of macular telangiectasia type 2. But I think it's really striking here is that when you look at the traditional angiogram, you can see leakage and staining, but even in the mid and early phase, you can't really see this level of detail of the microvasculature that you need to make this diagnosis, which is why I think OCT is so critical here. This is another patient, similar scenario, a 64-year-old woman with a history of diabetes who was referred for possible DME in the left eye. These are pretty, uninteresting color fundus photographs, although they are nice pictures. Really, we don't see any diabetic retinopathy, which is the first clue this patient probably doesn't have DME. You, again, maybe can squint and see that there's a little bit of discoloration in the parafoveal region. Again, the vessels seem a little close to the central fovea than I'm typically used to. But we look at our structural OCT, the right eye is actually totally normal. The left eye, we do see, again, more subtle inner retinal hyporeflective spaces. We see a small drusen. I would point out there's just a little bit of attenuation of the ISOS in the temporal parafoveal region in that right eye. Our FA is even less remarkable than on the prior case. The right eye, there's a very, very mild amount of staining in the temporal parafoveal region. The left eye is a little bit more prominent staining, maybe a little bit of late leakage, but in general, relatively bland traditional angiograms. Again, the OCTA will make the diagnosis in this case. If we look at the superficial capillary plexus, again, we see some draining venules in both eyes. I have a hard time identifying the feeding arteriole in the right eye. On the left eye, there's a definite dilated feeding arteriole coming from inferiorly. We do see a slight abnormality of the FAZ shape in that left eye, although the right eye looks relatively reasonable. Temporally, we do see, again, a little bit of rarefaction of the capillary bed with decreased vascular density, again, left eye more so than right. So this can be hard to make this diagnosis until you get to the deep capillary plexus. That left eye is incredibly diagnostic. You have, again, those widened capillary channels, and again, they tend to be clustered in the temporal region, which again, I think is very characteristic with macular telangiectasia type 2. And so again, this really highlights, I think, the utility of OCTA in making this diagnosis, which I think can be quite subtle. I think we make this diagnosis much, much better than we did maybe 10 years ago when, these patients were always, treated for CME or DME. And now I think, the kind of ophthalmology and optometry community at large are much better at identifying this, but I think it's still underdiagnosed. What are the benefits? I think we kind of highlighted that of using OCTA to make this diagnosis. I think one thing to think about is there's equal quality of the, vascular architecture that you can see on OCTA between the two eyes, as opposed to when you have one transit eye, right? In the case I just showed, if you transit the right eye, you'd say it's a totally normal eye, even from a microvascular perspective, because all you're going to see is that right eye early on, and then just a bunch of staining late. And that's point two, is that staining can really obscure what we really want to see in these cases, which is those changes to the parafoveal capillaries. Certainly you can see secondary subretinal neovascularization if it occurs very nicely with OCTA. And again, like any condition, the fact that OCTA is non-invasive and relatively quick is a real boon to our clinics, and certainly our patients like it. I think I want to close with just saying, highlighting why this diagnosis is important. And I think it's even more important today than it was, even 2 years ago. And that's because we finally have a treatment for macular telangiectasia type 2, which is this very interesting encapsulated cell implant device that's developed by Neurotech, which secretes CNTF and has been shown to slow the progression of this disease. Interestingly, if you look at some of the post hoc analyses from this device, we see that patients who are treated earlier on at earlier stages of their disease do much better. And so again, that's why we don't want to only find these patients when they have very obvious clinical findings, because that's probably too late. And so I think that's a nice plug for using OCTA in these patients.
Yeah, Eric, amazing cases. And I've got to say, it's incredible how we're able to take what was otherwise very difficult diagnoses and with OCT and OCTA to be able to identify this at a much earlier stage. So, Carolyn, I just want to ask you, could that second patient, a diabetic, we know that there's an increased prevalence of MACTEL in diabetics relative to non-diabetics. How do you know that that's not diabetic macular edema? Like, what is it that you're looking at on the OCT to help kind of clue you in?
Yeah, I think when we're looking at the OCT, if it's true edema, we're going to see like a thickening or expansion of the tissue. So your macular retinal thickness in that region is going to be abnormally thick, as opposed to if it's just, sort of atrophic spaces or cysts, like in this particular case in macular telangiectasia type 2, we're going to see thinning of tissue or atrophy of tissue, loss of the retinal layers. And I think that same sort of theory applies to what we were talking about earlier on interpreting OCT angiography in patients with geographic atrophy, how you could confuse that transmission artifact with choroidal neovascularization. But when you look at the cross-sectional structural OCT, it's thinning of tissue versus thickening of tissue.
And yeah, I love that. And Eric, do you feel like now with OCT and OCTA, is your use of fluorescein angiography completely sort of nullified? Is there any value at this point in time for you to get FA to make this diagnosis?
I think it's pretty diminishing, to be honest. I mean, it's interesting. I'm someone who really likes to point out these cases because I think I've always been fascinated by MACTEL2, and it's gotten to the point where my staff will see a patient before I've seen them and say, "Look, this is MACTEL2," just based on the structural OCT, and they've certainly even started to interpret some of the OCTAs. And again, these are scribes in our clinic, and so I think to be honest. I see little utility, for most of these cases. I do think there's still potentially some use in cases that are a little bit more equivalent, ambiguous than we saw, than these specific cases. But I do find that OCTA and OCT can make the diagnosis simply alone.
Yeah, absolutely. And, it's really important to the listeners that this is a Mueller cellopathy, effectively damage to the structural support cells of the retina. And I bring that up because tamoxifen is another medication that also damages Mueller cells. So when you are trying to make this diagnosis, always check the medication list to look for tamoxifen, as that can look very similar to that of MACTEL. So with that said, we're going to close up this section. We're going to go over to a question and answer. So please send us your questions and we're happy to discuss them.